Let's start at the cellular level, spermatogenesis. This process, which takes place in the seminiferous tubules of the testicles, is the cornerstone of male fertility. It takes approximately 74 days for sperm to fully mature, traveling through the seminiferous tubules, ribonate testis, and efferent ducts, before finally reaching the epididymis. In the epididymis, sperm gain the critical ability to move and fertilize an egg, and they are stored in the cauda until ejaculation. Infertility is defined based on age. For couples under 35, it's the inability to conceive after 12 months of regular, unprotected intercourse. For those 35 or older, the timeline shortens to 6 months. Did you know infertility affects about 15% of couples? Male factors contribute to 20 to 40% of cases. Proper evaluations prevent unnecessary interventions for women and can signal other male health concerns. Male infertility can be primary where the man was never fertile, or secondary where fertility declines. It can be classified by the location of the abnormality into 3 categories: pre-testicular, testicular, and post-testicular. Let's explore each type. Pre-testicular issues often involve hormonal imbalances. Hypogonadotropic hypogonadism is present when testosterone is low and gonadotropins are either low or normal. Remember that in the presence of low testosterone, normal FSH and LH levels are inappropriately normal because low testosterone should elevate gonadotropin levels. Treatment options include gonadotropins, selective estrogen receptor modulators, or aromatase inhibitors. While testosterone replacement increases serum testosterone, it can worsen fertility by lowering luteinizing hormone, decreasing intratesticular androgens, and impairing spermatogenesis. If a prolactinoma is suspected and the initial prolactin level is elevated, repeat the test to rule out an error. If prolactin remains consistently elevated, obtain a brain MRI. Testicular causes of infertility cover a wide range of conditions. Let's break them down. First up is primary testicular failure or hypergonadotropic hypogonadism. This is caused by a testis defect, resulting in low testosterone despite an elevated LH. Next we have Klinefelter syndrome. Men with this condition typically have small, firm testes, gynecomastia, and azoospermia, alongside hypergonadotropic hypogonadism. Sertoli cell-only syndrome is a condition where germ cells are entirely absent. In other words, there are only Sertoli cells in the seminiferous tubules. Other causes include maturation arrest, which is when spermatogenesis is halted at a particular stage, resulting in failure to complete spermatogenesis; cryptorchidism, CFTR mutations often linked to congenital bilateral absence of the vas deferens; history of genital infections. Infections like mumps can cause lasting damage to the testicles, and varicocele. Certain substances harm fertility. Think antibiotics, drugs of abuse, or even chemotherapy. Post-testicular causes often involve structural issues like ejaculatory duct obstruction. Symptoms include hematospermia, painful ejaculation, and low-volume ejaculate. TRUS findings suggest EDO when the seminal vesicle diameter exceeds 15 millimeters, or ejaculatory duct diameter exceeds 2.3 millimeters. Congenital bilateral absence of the vas deferens often presents with absent or atrophic seminal vesicles. Men with CBAVD have no palpable vasa, unlike those with EDO. The initial steps in infertility assessment involve evaluating both partners. Start with a reproductive history and semen analysis. Remember, at least 2 samples are needed 1 month apart to account for variability. This table provides a quick recap of common semen analysis terms. Don't forget to keep reference values like ejaculate volume, pH, and motility in mind for a complete picture. Infertility workups include an endocrine evaluation, indicated when any of the following are present: abnormal semen analysis, especially when sperm concentration is less than 10 million per milliliter, impaired sexual function, and other findings that suggest endocrinopathy. The minimum evaluation includes morning serum total testosterone and FSH. If testosterone is low, repeat it with free or bioavailable testosterone, prolactin, estradiol, and LH. Post-ejaculation urinalysis. For semen, volume less than 1.5 milliliters in the absence of hypogonadism and CBAVD. Sperm presence in the urine suggests retrograde ejaculation. Scrotal ultrasound, when the physical exam is abnormal, and a transrectal ultrasound for men with low sperm count, low ejaculate volume, and palpable vasa. These tests provide insights into structural and functional issues to guide treatment. Small lifestyle changes can make a big difference. Avoid smoking, excessive alcohol, and stress. Treatment depends on the cause. Hormonal therapy addresses low testosterone. Surgery, such as varicocele repair, improves sperm production. For severe cases, assisted reproductive techniques like IVF or ICSI may be indicated.